next speaker, which is Dr. Nihal Adel Hassan. And she will be speaking on imaging in pediatric age group.
Yeah. Can you ask a question to the previous speaker?
Yeah.
So I just wanted to know, in these young children, you have hyperopic errors, you have myopic errors, and you have astigmatism along with it. So when would it be a good choice to convert a part of the cylinder into a spherical equivalent? Because what happens in these young children, if you have high astigmatism, diagnosis and optical management, because it's just not a white reflex, it can be the harbinger of serious diseases as well. So the first thing when the child comes to you, obviously, is the parents who are going to be talking. So a detailed history is very important, because a detailed history can take you to the etiology, and also one can predict the challenges in the management which are going to come up. So the onset of symptoms, as you would do in any case, when the child comes to you, there's diminution of vision. Usually, the parents would say leukocoria in a very young child, but in older children, probably when the child is unable to read, when he goes to school, that's the time they would present. So it could present towards a congenital or an acquired pathology. It could be a developmental cataract as well. The duration of symptoms is very important because they are predictors of diagnosis and also the etiology. Antenatal history, again, very important. Any history of fever or rash in the mother to rule out any torch infections. History of prematurity, again. Any treatment in the form of laser intravitreal injection, which could lead to, again, a cataract formation because of the injections or maybe otherwise. Any drug intake, any metabolic disorders, any history of delayed cry, that's very important. So all these things have to be taken when you're dealing with a child with cataract, because if you're going to operate, a lot of things would depend upon, the visual outcome would depend upon what the child has been through. So cataracts are sometimes associated with systemic disorders, and history of developmental delay along with any treatment taken, check the milestones of the child. So these are very important things when you're dealing with a child who has come to you for cataract surgery. So the evaluation goes, obviously, you as an ophthalmologist would do your ophthalmology examination assessment first when the child presents to you. The ancillary things what you can do are ultrasound, biometry has to be done if you're planning surgery. Examination of the parents is very important. A broad systemic examination, of course, you're not a pediatrician, but just a broad outlook. I mean, what the child has, maybe some kind of dysmorphic features, and yes, a pediatrician review is also important. So coming to a first thing when the child comes is obviously you see the white reflex. The visual acuity assessment, the age-appropriate tools and techniques should be employed. Yes, the child has a cataract, so you might not be able to do all these things like optocataract nystagmus. Yes, resistance to occlusion could be there depending upon the density of the cataract. And all these other tests, it all depends how small the child, how young the child is, and how dense is the cataract. So I'll just be taking you through one of this little child who comes. Can I have the video? Yeah, yeah. So if you see this little child, he's not really focusing at the torchlight. He's having some roving eye movements, like nystagmoid movements, trying to see with the peripheral visual field, if you see. So if you see, he's not really seeing the torchlight. He's looking up. He has some little nystagmus in his right gaze. Now he's trying to turn his head and see the torchlight. So this is very important. Now this could give you this could prognosticate the visual outcome. Because the child has a white cataract, we're not able to see the fundus. So he might be having a pale disc, or he might be having some other disorders. So this becomes a very important part of your examination, because it's a long process. The child would be coming to you for follow-up for a long period, and what you have to do is counsel the parents. The parents would think that, at least in this region, they think that it's like an adult cataract surgery. You operate on the cataract and the child should have good vision. But no, this is not the case. The counseling and talking to the parents is very important in this case. So then comes your anterior segment examination. Of course, you have this young 3-month-old child who's in the lap of the mother, and it's not possible to put the child on the slit lamp. So a handheld slit lamp is very important in these cases. You could get a lot of information, what you would get on a routine slit lamp examination for an older child. So you should look for all these features like microcornea, corneal opacities, synechiae, membranes, all the abnormalities like features of PFE, anterior PFE, any subluxation, a morphology of the cataract. If it's not white, probably you would be able to make out. Posterior segment examination, where the view allows you, yes, an indirect ophthalmoscopy examination is very good. And to rule out conditions such as PFE, you can have hemorrhages there, colobomas, as was very nicely shown by the previous speaker, optic disc and macular abnormalities. So it's just not the cataract. The visual outcome would depend basically on what's called the retina here. So the outcome is really dependent upon the condition of the retina, the condition of the optic nerve. Of course, distant direct ophthalmoscopy is one good thing in young children. You can just see if there's a good bright reflex or is there some kind of an opacity in between. Ocular motility examination, very important. Unilateral cataracts who usually have a strabismus. They can have nystagmus, which is again a pointer towards a poor visual outcome. So retinoscopy, if it's a unilateral cataract, yes, the other eye retinoscopy has to be done, very important, because your planning of IOL implantation, the power what you're going to use will be dependent on the other eye. And clinical examination of the parents, you have to see if it's a familial cause, you could have subtle opacities in the parents and they've never noticed it. So a dilated examination of the parents is also warranted where you think that it's going to be a familial cause. Investigations, coming to the investigation, the B scan, where you don't have a view of the retina, probably for retinal detachments, PFEs, hemorrhages, all these would come up with the B scan. So just to know the integrity of the posterior segment, you need to do a B scan. And ultrasound biomicroscopy, again, maybe for anterior segment dysgenesis or to assess the angle structures to rule out maybe subluxation. And sometimes, yes, if you have an AIOCT, it's a good tool. Why? Because see this child. So what happens in this child has unilateral cataract. He was not showing because he has so much glare. The moment you put light, he closes his eye. So the other thing is do the AIOCT where you don't have the glare. So it just takes a moment to take the pictures, and if you see there is a opacification in the lens. So this is just an ancillary tool, not to be done every time, because if you do a slit lamp examination, probably you'll get everything. Optical biometry is the best in older children, but in younger children, probably you would do an A scan and a manual keratometry to get the desired IOL power and accordingly have your target refraction. So this is just a handheld keratometer where when the child is sleeping, we could do the keratometry readings. And the axial length measurement, again, with the A scan, what you'll have to do, not very accurate as the IOL master, but yes, will give you a fairly good idea. So IOL power calculation, target your undercorrection, depending upon the age of the child, depending upon whether it's a unilateral or a bilateral cataract. If it's a bilateral cataract, all the investigations, which I'll be telling you in the next maybe 1 or 2 slides, that's it. In a unilateral cataract, as I told you, they would present as a white reflex, and most of them have strabismus. So probably, and all the investigations you would not require in a unilateral cataract because most times the commonest cause is PFV. So for a bilateral cataract, you need a detailed systemic examination, multidisciplinary approach with the help of a pediatrician, and see for any dysmorphic features. A laboratory investigations for all these bilateral cataracts is required to know the etiology of the cataract. So all these blood tests, what I've written, should be ordered depending upon what you think could be the cause in a child. So genetic testing, again, if it's familial, probably you know it's familial. We've examined the parents. But in other cases, sometimes the causes could be missed. It could be a harbinger of a serious disease later on. Of course, collaboration with the geneticists is crucial to interpret the results and for a comprehensive eye care. So I'd like to conclude here that the workup of pediatric cataract demands a meticulous and multidisciplinary approach. And pediatric ophthalmologists must integrate clinical, imaging, and genetic information to formulate an accurate diagnosis and tailored management plan. Thank you.
Thank you so much, Dr. Jaspreet. And